And my pleasure this morning to welcome Dr. Rakesh Arora, who we were residents together in Halifax, so we've known each other for many years, is the head of cardiac surgery at the University of Manitoba and in Winnipeg, and an expert in delirium, previous member and president of the Delirium Society, the World Delirium Society, I believe. And you've got the poster behind you, and today is World Delirium Day on 16th of March. How convenient. And we never see delirium here, so I don't know what you're talking about. But you're basically going to tell us is I felt like I was a balloon floating away in a fierce wind, and the tales from a delirious patient after heart surgery. And with that, welcome you, Rakesh, to go ahead with rounds, and people are going to join in as we go. So please share your screen.
Thank you very much. I'll just start my screen here. And I'm going to assume you can see it unless you can tell me otherwise. So thank you very much, Jeff, for that lovely introduction. It's a pleasure to be able to come back again, virtually at least, to present again to the group. This is a topic that I have been very passionate about, we'll say now for about 12 years, as I first started getting very interested in delirium. And this title is actually a quote from Terry McLeod, that some of you may know, a former CBC radio personality that we had the opportunity to provide heart surgery for him a few years ago, who unfortunately had post-operative delirium. And his video is quite telling in many ways. If you have a chance to watch it, I encourage you to look at his video, and I'll provide the clip for you in just a minute there. So these are my disclosures. I have no none of which have a direct relevance to this particular talk this morning. So again, here's Terry McLeod, and so we had given him all the materials, and some of the things we'll talk about today is how we prepare patients prior to surgery about the potential risk for delirium. We included as part of our consent process as well for heart surgery, and give an information package to the patient and their families about the various things that can happen on heart surgery, including delirium. And you'll see in this video that he talks about why I got this information, but he said, it's never going to happen to me. And lo and behold, he had delirium post-operatively. And he describes the experience like floating away like a balloon in a fierce wind and needing someone to pull him back to earth, and really talks about the impact that as we as healthcare professionals and bedside practitioners, nurses, and others can really play a role in helping people with delirium in very simple ways, such as basic communication, physical touch, etc., can have significant impacts on our patients. I'd like to thank JF, like Gary, as he mentioned, we've known each other since 1996 when we started residency, or when I started residency anyways in Halifax. He and I both moved into cardiac surgery at the same time in 97, and we have been steadfast friends ever since. So thank you very much for the invitation again today. As Jay had mentioned, this is another organization that we started a few years ago. I was a former president of the American Delirium Society in 2015, and our partners association, the European Delirium Association, had a meeting. We were invited to give a talk out there as a group of us in London in September of 2015. And in a pub after the long couple of days of conferences, we sat around after several beers, said, well, why don't we do something different around social media campaigns? And this is where this came from, was out of a beer napkin in a pub in London, where we came with this idea of doing the World Delirium Awareness Day. So this is now our 7th iteration of this actual event. It'll be all day today, where we have tweet chats and other Twitter social media activities going on to raise awareness around delirium for patients, practitioners, and healthcare administrators of how they can participate in improving delirium in our patients. So this is perhaps the most important slide, and if you have to leave early to go to the OR or other clinical duties, if you remember nothing else from this talk other than this slide, this is a paradigm Jim Rudolph, who is a geriatrician at Brown University, and I came up with a few years ago, really to articulate why our patients in cardiac surgery are at higher risk for delirium than, say, some other surgical specialties or other vulnerable older adults in the acute care setting. Our patients are getting older and sicker, and we've probably been lamenting this for the last 2 or 3 decades, but it really is in our backyard now, particularly now through COVID, where we've had patients wait much longer than we've had in the past, where they're coming in older and sicker. And we're actually seeing natural history disease in real time, in our case here in Manitoba in some ways. In addition to their cardiac disease and age, frailty, poor nutrition, psychosocial stressors, again, particularly in these last 2 years where people have not been going out and interacting as normal, all provide this baseline vulnerability. Next, going through the relatively large operation of cardiac surgery, the acute stress of being on the heart-lung machine, blood loss, fluid shifts, and so forth, add a second strike or second stressor to a vulnerable patient system. Lastly, the things we do in the perioperative space with regards to hemodynamic perturbations that may occur, limiting mobility, the use of certain medications such as narcotics and others, a very noisy environment in the ICU and the ward sometimes that leads to sleep deprivation is a third strike or post-event stressor that adds to this paradigm of 3 strikes that leads to poor outcomes, including delirium. So when we're going to talk about delirium, we really need to think about this in the entire patient journey. And this kind of dovetails to this other concept that I'm quite interested in, which is enhancing recovery after surgery and really addressing these vulnerabilities in patients from time when you first see them in clinic to the point where they're seen in follow-up clinic following a heart surgery. I'm going to address just a component of this, but know this fits into a larger process for the patient. It really addresses pre-door, so before they come into the hospital, all the way following their discharge back out to the community. And okay, so the last most important slide, as I mentioned, patients are getting older and sicker, and we've previously done a relatively straightforward evaluation of patients looking primarily at their cardiac disease. We'd like to be more comprehensive in developing an overall management plan that really addresses all the vulnerabilities an older adult coming in for heart surgery in the current era needs to be managed. What I don't want to do in 15 remaining minutes is talk about a bunch of data that will have zero permanency in your minds at this time in the morning. So I'm really going to talk about this in large concepts, but certainly happy to dive deeper in more granular details during the question period. So if there's any questions along the way, and if we don't get them to today, please email me or contact me. I'm happy to address them in more detail. Okay, so this is really a letter of where my journey in delirium started. This is my second year of practice, third year of practice here in Winnipeg, where the nurse manager gave me this letter from a patient who was particularly agitated after surgery. He actually grabbed a pair of scissors off the bedside table and stabbed one of our nurses with it. And he wrote this letter, which I've blown up a couple of particular quotes here that were impactful to us as a team and to me personally as well. First, that he wrote this as a letter of apology, which was striking in itself. And secondly, that he felt thoroughly ashamed of his behavior. Now, we felt it was unjust for a patient to feel this way after something that wasn't his fault, that he had delirium after surgery, that we didn't really have a good concept of how to identify it, one, and two, manage it thereafterwards. Certainly, we didn't bear this patient any ill will. Well, maybe the nurse got stabbed a little bit, but for the most part, we felt poorly that we didn't do well by this patient, that he had to write this letter, felt compelled to write this letter. Over the past decade, I think there's been a lot of research in both ICU patients and in particular in cardiac surgery, where some key things have been identified about delirium as it pertains to our patients. First, when you have delirium, like if you have any organ system dysfunction, be it kidney injury or lung dysfunction, such as ARDS after heart surgery, it's associated with increased mortality. In addition to those patients who have delirium, they often have longer ICU, hospital length of stay. In addition, higher rates of loss of functional independence. And we'll dive down to a little bit more why this occurs in the heart surgery patients in just a moment. Loss of independence can be small things such as being able not really do instrumented active daily living, or worse, when they lose functional independence altogether, such they're not able to go back to their own home. This can lead to long-term cognitive and mood disorders as well. So why is the cardiac surgery patient at particular risk for this in the perioperative space? A number of patients, as they get older, have some degree of cognitive dysfunction. And if you were to do a mini mental status exam or a MOCA exam, a Montreal Objective Cognitive Assessment, on our patients, about 1 to 4, 1 in 5 patients will have some degree of abnormalities consistent with mild cognitive dysfunction at baseline. It is unlikely that cardiopulmonary bypass will make that better. Compound that with high rates of frailty as our patients are getting older and sicker, it leads to high rates of delirium in our post-operative patients. Importantly, people from out of Harvard and elsewhere have identified that a number of things that we do in the perioperative space can lead to iatrogenic causes of delirium. So up to 40% of delirium that occurs in a postoperative patient may indeed be preventable by modifying how we take care of these patients in the perioperative space. So let me dive into that a little bit more. So when your patient actually has delirium or has risk for delirium, what can you do about it? We typically address postoperative delirium when we first see it in the postoperative phase. And what I'm going to advocate for you today is really how we can look at this further upstream in the preoperative phase to identify risk, put processes in place to mitigate delirium from occurring in the first place. As I'm sure many of you are aware, once delirium occurs, it can be quite difficult to manage, and there's really no good treatment for the patients once it occurs. Much in the same way when someone has new acute kidney injury, their creatinine's gone up, they have low urine output, the injury has already occurred. And really now you're trying to manage further injury to the kidneys to prevent full-blown renal failure. Much in the same way, once delirium has occurred, the brain injury that portends the delirium, the symptom of brain injury, it's already occurred. So really you missed the boat, and now you're just trying to manage it from getting worse or causing long-term insult. So we have developed a risk stratification tool. There are a number of those ones out there. This one was developed after looking at about 2,000 of our patients, where we identified several different risk factors that were associated with delirium in a postoperative patient. So all patients come through and are screened with a baseline frailty assessment, an objective cognitive assessment, as well as mood disorders, as well as nutrition and other factors that are related to the occurrence of delirium, and give them a score. The score is based on a low, medium, or high risk. If someone's deemed to be at high risk for a delirium, they're labeled on their chart and get a little blue armband to indicate delirium risk. So when they come in through the door for the preoperative assessment on the day of surgery, and in the operating room where we do our WHO mandated checklist in the operating room as part of our timeout process, we identify risk of delirium in that patient, and the anesthesiologist will modify their practice of how they provide anesthetics, and we look to potentially ultra fast track those patients by extubating the OR wherever possible. And I'll explain a bit more about that in a moment. But really, this really identifies a whole team. This patient has a vulnerability that may not be readily apparent when they walk through the door, but really attunes the whole patient that this patient has some degree of risk that we want to pay attention to. Once you've identified risk in a preoperative patient, then you want to do a deliberate screen for delirium in the postoperative phase. So much like using creatinine, when you see a small bump in creatinine, you get concerned about injury to the kidneys. The same when you have here, when you have some features that are associated with delirium, which are characterized by four things. So a change in their mental status from baseline, features of inattention, altered levels of consciousness, so either too sleepy or too agitated, or any features of disorganized thinking, all kind of portend the risk of delirium in your patient, or the occurrence of delirium in your patient. There are a number of different systematic scoring tools out there that really look at the spectrum of delirium, from those who are very sleepy or hypoactive to those being hyperactive or agitated. These are two of the most common ones used in the ICUs. You're probably using one of these in your ICU now. We tend to use the CAM ICU tool because it really requires the team member to go and examine the patient and interact with them on a regular basis. The intensive care delirium screen checklist is also a well-validated tool that a number of centers in Canada are using, and requires using a checklist at the end of a particular nursing shift or an interval period of time of observation. Both work well. We just have a tendency to use the CAM ICU tool, but as long as you're using some tool that really looks for the spectrum of delirium occurrence or presentation is really the important part. But what about the postoperative ward? We tend to forget about this a little bit, but about up to a third of our patients will have delirium for the first time on the postoperative ward. And the tools that we use in the ICU, where useful, are not necessarily as easily done on a postoperative ward, where your nursing ratios may be 1:4, 1:5, or 1:6, depending on your particular system, where it's not as easy for a nurse to go run around and assess patients in as comprehensive way. So modifying tools are really important to be allowed this to be done as part of your normal workflow for the number of patients you're looking after. So there are different tools out there for the post-operative ward. There is a confusion assessment method, or CAM, for the ward, called a 3D CAM or brief CAM. This is another tool that we started using called the 4AT, or the 4A's test, where it really looks at 4 features of delirium again, but really starts with arousal as being the most important one. So any patient that has any degree of sleepiness or abnormal alertness automatically gets labeled as potentially delirious and requires further assessment. When someone's identified as being delirious, either in the ICU or the ward, you really need to treat that as a medical emergency. And we can talk a little bit more about that perhaps in the discussion period. But again, in the same way that we look at delirium in the ICU, we need a comprehensive and easy to use tool in the post-operative phase on a ward as well. So we looked at this particular tool, the 4A's test, on our post-operative ward a couple of years ago now. And we found in general that when it's administered by any team member, particularly by the research teams, it actually picked up delirium at a much higher rate than our previous used confusion assessment method tool. When nurses used it, they generally liked it, but it does require a little bit extra work around how you implement your team, but in general improved our identification of delirium and overall awareness of delirium as an important issue in the post-operative patient. And we identified a lot of patients who would have otherwise been labeled as being normal from a cognition standpoint in the post-operative phase. So when you identify someone with delirium, looking for the underlying cause is really important, and really trying to identify the etiology of delirium, treating it as rapidly as possible to prevent long-term propagation of delirium in patients, which can lead to long-term negative outcomes. There are a number of mnemonics out there to help you with this. I remember none of them, but this is one example of one called Pinch Me that we did in the World Delirium Awareness Day a couple of years ago to give you a mnemonic of how to approach a patient who may have delirium. I'm not going to have time to go through all of these, so I'll focus on a couple. One around medication. So if we blow that up a little bigger, the Pinch Me mnemonic, when we focus on medication as a potential cause for delirium, can be kind of divided in 2 basic columns. So those of medications that were on preoperatively that you may not have restarted, that may be important for those patients, such as long-term mood medications or others, or the addition of new medications that may have impacts on post-operative delirium. These are then the categories listed for you below. Probably the one we've overlooked the most are those with anticholinergic properties that can cause a dysregulation of neurotransmission in the brain in key areas that may be associated with delirium. Things such as Maxaran for gut motility, Lasix, post-operative use of ranitidine, all have anticholinergic effects that can promote delirium in your patient. In addition, benzodiazepine, I think, is now well recognized as a potential cause of delirium in post-operative patients, as well as the use of opioids or narcotics for post-operative pain medication. So in addition to looking through medications for the patients, there are a number of different things you can do from a non-pharmacologic strategy to help your patients with post-operative orientation and limiting loss of our normal 5 senses we have that we take for granted, such as sight, smell, taste, mobility, and sleep in the post-operative phase that can be impacted. And so this is a really clever a diagram that we put out this year for our World Delirium Awareness Day. If you can spot 10 things that are different between the top picture and the lower picture, I'm sure you could scrutinize this for half an hour. I got as high as 7, but there are a number in there. And if you actually look through this picture, things such as orientation, having a calendar in the room, having a watch on the patient they have it, or a clock that's easily visible, making sure they have the glasses and or hearing aids in, and having natural light if possible, or at least lights on during the day to stimulate normal circadian rhythm balance within the brain, so no day versus night visual cues. Maintaining adequate intravascular volume. You don't want them to be dehydrated, but you probably equally don't want them to be fluid overloaded. Avoiding the use of lines and tubes and catheters wherever possible when they're ready to come out to take them out. To ensure adequate nutrition and any mobility aids that may be important. And lastly, cleaning. So for performing infection, so having an appropriately cleaned room and or patient is also important as part of that process for things you can do to prevent delirium in your post-operative patient in the ICU and on the ward. So just some practical tips and tricks that don't require any specific increased cost or medications. So speaking about medications, much like Lasix doesn't treat kidney failure, acute kidney injury, antipsychotics don't treat delirium. It only mitigates really agitated symptoms to help your patient for a safety standpoint, but really doesn't treat the underlying cause. The underlying cause being infection or other drugs you're giving them that may be causing delirium or other various factors that we can try to mitigate or things we should target rather than treating with antipsychotics. There are several studies now showing that prophylactic use of antipsychotics or the use of antipsychotics postoperatively doesn't change the overall course of delirium, that it really has to run its course once it occurs. So the current recommendation specifically about the use of antipsychotics in our patients is really for just treating those patients who have really worrisome symptoms. So those who are hallucinating or have really paranoid delusions with fearfulness or significant agitation or their physical harm to themselves or others are where short-term doses of antipsychotics should be used. One of the things we talked on our podcast a couple of days ago around the use of antipsychotics in being used in an unmonitored or an indefinite period of fashion where you're giving the drugs without any stop date should really be considered in this day and age as a medical error. If you're going to use antipsychotics, like any medication, it should be used at the lowest effective dose for the shortest period of time. That being said, when we look specifically at the cardiac surgery patient, and we'll have a paper coming out in this recently looking at this in the post-operative cardiac surgery patient, you may be using dexmedetomidine more routinely as part of your intraoperative and early post-operative phase of care for your patients as well. There is some data suggesting that the use of this particular medication, which works similar to clonidine as an alpha-2 agonist, may have some impact on reducing the time for mechanical ventilation and thereby decreasing the need for sedation and narcotics, which may have an impact on delirium. One of the next issues that we should talk about briefly is about how we treat pain. I think as we've evolved our understanding from enhanced recovery pathways, the traditional approach of using high-dose opioids in the postoperative phase may not be the most effective way to manage postoperative discomfort. Certainly pain, and we all recognize through a traditional median sternotomy is associated with pain after surgery, most commonly in the first 2 to 3 days, and really kind of tapers off markedly thereafterwards. For most of us included, opioids has been the mainstay of our management strategy until more recently, where we have developed a multimodal approach to managing postoperative pain discomfort with agents outside of the use of opioids. But really importantly, as I mentioned earlier, starting with this discussion around how you're going to manage a patient's discomfort after the operation should start in the preoperative phase. Having the discussion what discomfort may look like, understanding that we won't be taking a patient's pain away entirely, but trying to get to a point where they have a manageable level of discomfort, they can mobilize and do the deep breathing and coughing exercises they meant to do in the postoperative phase is important. And using combination of Tylenol and other medications, including Neuraxil blocks and so forth, has really become part of the armamentarium for the contemporary perioperative cardiac surgery team. Next, and perhaps a little less commonly done, particularly in Canada due to cost, is the use of rigid sternal fixation. The use of this which has been allowed for earlier mobilization and less postoperative discomfort for those who have a traditional full median sternotomy may also provide benefit in reducing pain and therefore risk of delirium postoperatively as well. One other agent to think about is the use of intravenous acetaminophen. We are looking at this as a trial now as part of a CHR funded grant that we're putting in for this season, looking at the use of Tylenol versus other medications. This is an important study from Bala Subramanian from the Beth Israel Deaconess in Boston. It's a trial called the DEXACET trial, where they looked at the mixture of dexmedetomidine or intravenous acetaminophen in a 2x2 table design. They found the actual use of IV acetaminophen improved pain management postoperatively, but also was associated with less delirium. So this is being done as a larger study now called the Pandora trial that we're anxiously waiting the data from to see if the use of this particular agent as a prophylactic drug in the perioperative space may improve both pain management as well as occurrence of postoperative delirium. So when you take this very holistic approach, again, it sounds like a lot to do. And in fact, it is a lot to do for our patients, but it's all part of the enhanced recovery pathway. But what could this actually look like for your patient coming out of the ICU? Coming out of the operating room to the ICU. So this is a video that I'll show 2 short clips of a 74-year-old gentleman that came into our intensive care unit after just immigrating to the country from the Philippines 2 weeks prior. So he got in a plane, was having chest pain, came to our hospital, St. Barnabas Hospital. A gentleman who really does not speak English, who had a pretty extensive smoking and ethanol alcohol use. So really one of the high-risk hospital delirium patients you could have coming in to a cardiac surgery procedure, coming in for combined heart valve procedure with a low EF. So there isn't any higher risk kind of patient you could have. So this is a patient who just came out of the operating room. He has been extubated in the operating room and just being parked in an intensive care unit. And you can see how cognitively aware and how comfortable he is coming out. Now you may not be able to hear the audio for this on your end, but you can see we put his glasses on. We have him sitting up with a well-lit room, and we gave him a newspaper to read. So for those who are astute in the audience, I've told you he doesn't speak English, and we've given a paper written in English. He's probably just looking at pictures and actually may not be doing anything that requires any executive cognitive function. So we gave him an iPad to play solitaire to see how well he could, again, function in the post-operative phase just after arriving to the ICU. So again, he's able to hold the iPad, which he's never used before. He knew how to play solitaire, and has been able to figure out how to use his device, play the game appropriately, and was comfortable and interact with our team to be able to tell us how he's doing. So I think this is an example of what enhanced recovery pathway can look like when you incorporate all the things that are important for patient care, as well as reduction of delirium in the post-operative phase. Okay, so to wrap things up, I'll summarize in the next minute here of what I've talked about today, and again, can dive into any part of this in more detail. The three major takeaway points from this talk, I think, is that we need to look for delirium throughout the patient journey, starting with it in the preoperative phase to identify a risk. If there is a risk of delirium that's been identified, finding ways to optimize it to the best of our ability prior to surgery. When they're in the hospital, using a dedicated screening tool to identify delirium at the earliest possible time point, as well as putting measures in place to mitigate the risk from occurring in the first place. If delirium does occur, finding the reasons for why it occurs as early as possible, treating the underlying cause, and try to minimize the duration of delirium to the best of our ability. Lastly, one area that I didn't talk about in the interest of time today is how you prepare the patient for discharge of that delirium, but effective communication to the patient, their caregivers, and their primary care practitioner of the occurrence of delirium and what to look out for in the long term is also important as well. Again, if you have someone you've identified for risk for delirium, consider ways to minimize that in the perioperative phase is key. And then lastly, with regards to medications, trying to find ways to mitigate use of drugs that may promote delirium and use a lot of non-pharmacologic or non-opioid strategies to manage your postoperative discomfort is important. Lastly, to summarize, I want to get one more key announcement for today on World Delirium Awareness Day. We're very excited to launch 2 new peer-reviewed journals for delirium. We've been working on this for about 8 years. It's now coming to fruition today. So we have 2 new open access journals launched today, Delirium for more high-impact research articles that really should change practice, as well as Delirium Communications, which are shorter sort of communications around processes or techniques, is launching today as well. So I encourage you to check out these 2 websites in our YouTube channel related to our new Delirium journal. So with that, I'll stop there. Thank you very much for the opportunity to speak to you today on delirium, a topic that I'm clearly very passionate about, and I'm happy to take any questions there afterwards. Thanks very much.
Thank you, Rakesh. This is great. If beautiful kids. If you don't mind unsharing your screen, they will just put you back into focus there. So I'll let the people, if you have any questions, put them on the chat box if you like, or raise your hand. I certainly have a question. You know, I sort of feel in my mind that you've contributed to this, that we've evolved quite a bit in the last 10, 15, 20 years in terms of our awareness, our ability to potentially think about prevention and the management, maybe a little less so, but it's sort of the way I see it. But I'm still struggling a little bit on our ability to screen and to capture the screening, and to then at the same time be able to measure properly when we make changes to what we do. How do we know that we're doing better? And just your insights along that, because you've obviously gone through that spectrum, and sometimes, you know, we're putting a lot of work on nurses that are already very busy on the floor. You know, can you please do this one more screening tool? You know, we do it for shock, we do it for this, we do it for bed wounds, we do, you know, how do we sort of navigate that?
Yeah, 100%. So that's a really, really important observation. So one, tracking your data is key. So we looked at our data initially when we didn't do a formal delirium screen, and our rates of delirium were around 8 to 9%. Once we implemented a formal delirium screening tool, we found that our rates went up to about 20 to 25%. So we had a higher rate of detection. And you ask, well, why does that matter? Well, when you actually look at 1-year outcome data for those who have been screened with a formal delirium screening tool versus others, when you actually have a delirium screening tool in place, it actually predicts 1-year mortality better. So identifying risk of delirium seems to have a significant impact on a hard outcome such as mortality. Second, we looked at the overall rates of delirium over time as we've had iterative changes in our processes. And in general, we've seen a gradual reduction in delirium. And so again, what we're trying to tackle is that 40% of delirium that may be associated with what we do as processing care. We're not going to take away delirium altogether. That is likely unachievable, though that's the goal we're always striving towards. But then other metrics that are associated with delirium are important as quality metrics for your team. So the risks of falls have been tightly linked to the occurrence of delirium and costs associated with constant care. So we've used those metrics to, again, display to our team how effective we have or have not been with our delirium management and screening processes. So we found over the first few years that our FTE allotment for constant care, for example, went from 4.2 down to about 1.8 in the span of 2 years. So significant cost savings, which is a marker of the severity of delirium that we had in the ward. And two, our overall fall rates have gone down as well. So those are important metrics for the teams to kind of latch onto that helps justify the increased work. But the last point is also really important as well, is about how do you integrate it into your current workflow? And I'll be honest, we're still trying to figure that out as well, because it's extra time. Every new thing you do has to either replace something else or be better than what they're doing before. And I think tools like the 4AT that can be a really simple screen is the way to kind of do a rapid assessment of patients without adding a lot of increased burden to their workload for a very busy ward practice, as an example.
Is the 4AT, the way you guys do it, easy to track after in terms of more of a research, or is it tracked through nursing sheet, that kind of stuff?
Yeah, so the way we've done it, so we're a little behind our electronic patient medical records, so we still capture CAM on our EMR, but if we're using the 4AT, we just label that person as being CAM positive for that particular assessment on the EMR, but it's really 4AT versus CAM. But the nice thing with the CAM is if you're a patient, so another major takeaway, if your patient's sleepy, so a sleepy patient is a delirious patient until you can prove otherwise. Yes. Hypoactive delirium occurs probably 50% time, probably more commonly on the ward. So if you have a sleepy patient, assume that patient's delirious unless you can prove to your team or yourself that they're not.
Yes. I have a question from Craig, and it's a good one in the sense that, COVID has obviously affected the way we allow families to come in, and we certainly get that sense that this disconnect now with patients in the hospital, the stress involved, there's not that clear line. And what's your impression on this?
Yeah, so spot on. Yeah, so we've seen an increase in delirium and constant care in the ICU and the wards over the last 2 years. So spot on for that observation. And I think there's a number of tools out there now which really highlight the importance of family as part of delirium identification and management. So there's a term called SQUID, or single question in delirium. And so just by asking a family member or someone who knows the patient well, does Mr. or Mrs. So-and-so seem different to you today, can be a very good initial screen for your team to say, well, that patient's not themselves. And so not having family around and that early identification that may be much more sensitive than even our good systematic screening tools may be important. So certainly we've seen some changes in the absence of family being around that have probably increased our delirium rates in the postoperative phase and in the ICU.
Very good. So for our last question, it's a tough one from Ron, who's one of our cardiologists in Moncton. So I'll read the question. So is the high mortality associated with delirium due to the underlying patient characteristic, is the first part of the question. And do interventions to screen or prevent delirium actually improve the survival? So is there a link to the outcome, is obviously. And I'll stop there because the question goes on a little bit, but I think those two are absolutely critical. Yeah.
Yeah, so I think if we extrapolate data from non-cardiac surgery patients, because that's probably where most of this work has been done, because it's a much larger population, that in ICU and acute hospital admissions, an ounce of prevention can lead to significant impacts in the occurrence of postoperative delirium and then therefore mortality. So say, for example, you have two patients, they're both frail. We'll talk about cardiac surgery specifically right now. If you have a frail patient that has delirium, the risk of mortality is 5-fold increased higher in those patients that don't have delirium in a cardiac surgery patient. So that's major adverse cardiovascular, cerebrovascular events. If you can prevent delirium in those patients, absolutely you can change mortality in those patients from that extra period of brain dysfunction. So like any organ dysfunction occurs after heart surgery, be it kidney injury, lung injury, et cetera, as I mentioned. Brain dysfunction can be considered as another organ dysfunction that we must mitigate. And this goes back to one of the points I was making earlier. When you have delirium, you must treat it like a medical emergency in the same way if someone had a cardiac index of 1.6 for 4 hours or no urine output for 3 hours. Those would be hard alerts for your perioperative saying, this is something abnormal. A person with new brain dysfunction has to be treated the same way. And if you're not identifying those patients and treating them rapidly, in the same way, if you don't treat heart failure rapidly, it leads to negative outcomes. And so treating delirium as a medical emergency is key. Part of that's also just a way the terminology that you use. So using terms such as that patient's pleasantly confused doesn't really help know the severity of the situation. We don't use terms like that's really beautiful heart failure or really attractive respiratory distress. We probably shouldn't be using terms that aren't really helpful to help the team alert that there's a problem with brain dysfunction.
Yes. With this, Rakesh, these are outstanding rounds, and thank you very much for giving this to us and giving some thought. And I'm sure there's much more to do and to learn from this. Thank you.
Thank you very much, guys. Thanks for the opportunity.
Have a wonderful day, everybody. Thank you. Bye-bye.